All right, everyone. This is week 10, health and medicine. Um, it's altered a little bit to include science, so it's more like medicine and health. We will be specifically looking at systems. So, how are health and science or medicine and science part of systems? Social systems. Remember, social systems have four parts: patterned interactions, a network, of individuals, organizations, and institutions, a hierarchy, and norms of behavior, ideas, and attitudes, right? So we will be looking at how medicine and science act as systems and can't just be seen as, just medicine or just science. So let's look at the quick to kind of preempt our reading into Quadanyo and our the podcast. Let's look at the healthcare system quick facts. That in the U.S., almost 20% of GDP is spent on health. GDP is the entirety of money that is made in the U.S. economic marketplace. So 20% of that um, is spent on health. The U.S., it's in everyone in the U.S., that's about $4.1 trillion on healthcare in 2021. Healthcare is super expensive. Two-thirds of all bankruptcies in the U.S. cite healthcare costs. And in 2019, this was about 700,000 people, so almost a million people filing for bankruptcy. Um, One of the problems here is that healthcare spending per person in the US is the highest in the world, yet it doesn't necessarily improve health. So if we see on the right part of the graph that the US has one of the lowest life expectancies among other developed countries like Switzerland, Canada, Australia, yet it spends almost, in some cases, more than four times or more than twice as much. So France, for example, spends around 5,000 per person, maybe a little bit over 4,000 per person, and their life expectancy is around 82, whereas we spend over 10,000 per person, and our life expectancy is only 78.5. Another way of visualizing this is the amount of deaths per 100,000 people in each of these countries that could have been avoided if there was healthcare. And so we see in the US that we have in 2004 and 2014, we have the highest deaths per 100,000 people that could have been prevented if there was adequate health care. Again, this is compared to the rest of the industrialized worlds. So let's look at why. And this is understanding health as and medicine as a system is imperative in understanding how and why these are happening. So Quadanyo argues that there are three aspects of healthcare reform that we need to think about. The first one is institutions, and this really helps looking at the different kinds of the network of people, organizations, and institutions. So she focuses on care delivery, like hospitals, practices, and clinics, as well as the financing of care, governments, agencies, states, private insurance, etc. And one way to look at how these institutions might be arranged is by listening to the Pitchfork Economics episode with T.R. Reid. You could also watch the PBS documentary on this. But essentially, he says that there are four basic healthcare models throughout the world. And this is depending on whether the government is involved in providing healthcare or the government is involved in paying for healthcare. On the other side, it would be private. So remember, when we're talking about government-run healthcare, that means the government is in control of the government employs the doctors, runs the hospitals, etc. Private run healthcare is when corporations or individuals run healthcare. So whether that is, Northwestern Medicine or a private practitioner, that is private run healthcare. Government run payment means that the government funds the insurance, whereas private run payment means that you are paying insurance to private companies like Aetna rather than the US government. So there are four basic healthcare models. The first is when everything is run by the government. both the healthcare and the payment. We see this in the UK as well as, I mean, it's throughout the world. Cuba has this as well. So government-run healthcare, the government provides healthcare as well as pays for it. This usually is included in higher taxes. Full private is when both private companies run the healthcare space as well as are the insurance companies. The most famous examples are Germany and Japan. The reason why this is part of the healthcare model, even though it's not state funded, is because there is a requirement in the state that everyone have access to healthcare. So even though it's run by private companies, everyone has access, and the government will subsidize private payments for low-income individuals who are accessing healthcare. Public-private is what you see in Canada, and T.R. Reid says it's best implemented in Australia, but this is where the hospitals and doctors are privately owned, but the government runs the insurance program. And then finally, you have the healthcare models, generally in poor nations, where the only thing you can do is private healthcare because the government has not made a specific mandate that everyone deserves healthcare. So, as I said, the first three models are by countries who have decided to ensure all citizens have healthcare, whereas the fourth model is where countries either cannot guarantee or will not guarantee healthcare to all of its citizens. So the question then is, where does the US stand? What is our healthcare system? T.R. Reid says it actually is all four. That for veterans, you have a government-run healthcare with the VA and government-run payment system. For your average employee or your able-bodied adult, you have full private, where you go to private hospitals and you pay private insurance companies. If you are elderly or if you are in poverty, then you probably are in a public-private system where you go to a private hospital or private doctor, but you get the government to pay for your medical bills. And then finally, there's no healthcare model for over 26.1 million people in the US. They have no guaranteed right or guaranteed provision of health coverage. And this is what Obamacare was supposed to address, and still hasn't, as 8% of the country is still uninsured. So that is Guadagno's look at institutions. How do institutions affect the social system of healthcare? Now we're going to look at ideology, which is part of the norms, right? The beliefs, the attitudes, and Guadagno argues that in the world there are generally two ideas of healthcare, two norms. First is healthcare as a right, which is more of a social solidarity, that we should all be in it together to make sure we're uplifting everyone. And this is what you see in those first three models: UK, Cuba, Germany, Japan, Australia, Canada, right? They've all said that healthcare is a right. And then the market principle is healthcare as a commodity. This is when the government should be completely out of it and let the market forces be off on their own. And this is what you see in the case of the poorer countries as well as a lot of the US. And even though Germany has a private system, it is still not the idea that healthcare is a commodity. It's still that everyone is guaranteed healthcare as a right. It's just that they allow the market to organize healthcare, and then the government steps in when people who cannot afford it. So these lead questions of, in the US, who has a right to healthcare and who doesn't. So people who have a right to healthcare are veterans, are the elderly. But this also means that many people don't have a right to healthcare. Usually working age adults who might not have a job suddenly are out of healthcare, and they lose any ability to pay for or access healthcare. And this raises questions about how do we categorize people? How do we value them? Some of the people who can't get healthcare are undocumented immigrants. And so it's another group of people that the US has decided don't deserve a right to healthcare, whereas for many other countries, this has been easy to resolve. And then some other players in this network of relationships are interest groups in social movements. As an example, many of the top lobbying industries were healthcare related. So pharmaceuticals are the most are spending the most in lobbying of all industries. Hospitals and nursing homes are in the top 10, as well as health professionals and health services. And then when we look at social movements have been imperative in healthcare throughout our country's history. We look at the AIDS epidemic of the 1980s, that social movements had convinced hospitals and doctors to treat AIDS. And there was a big fight that the FDA needed to fast track AIDS drugs, which they were refusing to do until these social movements. The Black Panthers and other civil rights movements were big on addressing healthcare inequalities and discrimination. So it was actually the Black Panthers that led the first sickle cell anemia testing, as well. And one of the first areas of desegregation was in hospitals. And then right now, there's quite a movement for helping immigrants in the US be able to have healthcare accessible when many of them have come not by their choice, but are here for their parents or for asylum and still do not have access. So social movements are a big feature in the system of healthcare. And so when we look at it as a system, here are some of the questions you'll want to think about. What are the ordered arrangements of interactions? So when do patients come into the system? Are they ever out of the system? How do you interact with doctors? How do doctors and nurses interact? Scientists versus insurance, etc. You can look at the pattern network of relationships that we've kind of looked at, and then the hierarchy, norms, and behaviors. So arrangement of interactions, here are some of the ideas from the textbook, where you have the sickness model versus preventative care, whether we're stigmatizing illnesses. So are we putting patients in asylums? Are we putting them in shelters? Or are we sending them home? How does the insurance determine how physicians treat their patients? What are government policies on healthcare for their citizens? These are how they arrange interactions. Then we look at the networks of relationships between all of these people, groups, and institutions. So it's the patient doctor, patient nurse, insurance hospital, etc. And then what are the hierarchies and norms? These are, again, are parts of the readings that you had that you can look at. This is how sociologists look at healthcare as a system. Next, we're going to look at science as a system. So we're using Petrina's offshoring clinical trials, as well as John Oliver's video on scientific studies. Again, we are looking at these 4 parts: ordered arrangement of interactions, pattern networks of relationships, hierarchies, and norms. So let's start with the offshore clinical trials. In her piece, Petrina looks at what are the big organizations and institutions that are affecting why clinical trials are moving offshore. Specifically, why are they contracting these research organizations, or CROs, to go offshore or to recruit people for clinical trials? And she denotes there's pharma companies, US regulators, non-Americans who are off prescriptions, whereas Americans are on prescriptions, foreign governments, US patent offices. These are all parts of people and institutions that are involved in the clinical trial process that affect how science is done. When we look at John Oliver's piece on science studies, we have some of these pattern networks of relationships. You have the media, research subjects, publishers who are pressuring them to publish and making it expensive. You have the scientific community that's reviewing the research. You have university and departments who are pushing scientists to research. graduate students, tenure committees, right? So these are all different players in that make science a science. Next, when we look at the ordered arrangement of interactions on the offshoring clinical trial side, we look at the processes required to get FDA approval, the requirements for a number of trials and test subjects. Um, a lot of the international test subjects will come into clinical trials because they want specialized care for a certain disease. She says this is why a lot of Eastern Europeans will get included in clinical trials because of the history of, Chernobyl and radiation, and that they're looking for specific care that is otherwise unavailable. And then some clinical trials are deliberately seeking informed consumers versus naive consumers. So it's ordering who is interacting with these clinical trials based on the kind of clients they want. For scientific studies, some of the ordered arrangements of interaction include grant applications for funding, tenure applications, how to write and publish new studies, media segments, etc. And there are clear hierarchies in each of these. First, Patrina looks at the third world subjects that are being taken advantage of during these offshore clinical trials, in which they're creating drugs not for the third world individuals, but for first world consumers. They're looking to make a profit, and that's why the corporate profits are at the top of this hierarchy. One of the hierarchies in scientific studies is simply the professional track for scientists. You're looking at adjunct professors that are non-tenure track, and then you look at tenure track means they are people who are looking for a full-time lifetime appointment. So when a professor says they got tenure, that generally means that they cannot be fired except for sexual harassment or really being terrible at their, but they cannot be fired for having views that are controversial. They can't be fired for poor instruction or things like that. Their job might be changed, but they have a lifetime appointment. So to get to tenure, it's all about what they call publish or perish, or the idea that you need to publish new research that shows that you've made an impact in the field. And so what are some of the norms, behaviors, and ideologies on offshore clinical trials? She talks a lot about the drive for profit is funding most of this, and it is what is giving a lot on the Me Too drugs. Me Too drugs are when there's an existing drug on the market already, other pharmaceutical companies will look to copy that drug to get a share of the profit in that industry. And that's why you have a whole bunch of different kinds of anxiety drugs, a whole bunch of different kinds of depression drugs that all do the same thing, but they are all trying to gather a share of that market. So it's a big issue with profit. Some of the norms are that we should have informed consent, whereas a lot of these offshore clinical trials avoid informed consent. They look for naive people to come in and do their clinical trials. Another behavior that is common in offshore clinical trial is the history of liability testing. She marks that through the OS, liability testing was often done on prison populations. Liability testing is when drug companies test specifically to find adverse reactions and effects. They usually expect there to be an adverse reaction. They want to know what it is. And so they will test it on already marginalized populations. And in the past, this used to be prisoners. That has been banned, and so now they are using offshore clinical trials as a way to check for adverse reactions. On the scientific studies side, we have the publish or perish ideology that in order to publish or in order to gain tenure or to advance in your career, you have to publish, and that they have to be new findings rather than replicating and ensuring that past findings are accurate. Media is involved by wanting a edgy or new or fun result. So John Oliver goes through how they really push for things like drinking a cup of coffee a day can cure cancer. And then the next week, drinking a cup of coffee a day will give you diabetes, right? So they're really trying to find this flashy study, whereas within scientific community, the norm is you can't just base it on one scientific study. You have to base it on the entire scientific literature, which often takes decades to establish a scientific fact rather than just one study. So those are some of the issues that we look at when looking at science and medicine as a system. If you have questions, please let me know. And I look forward to next week's topic on social change.